Our starting point is that health is wealth. The world over, there is a clear and unequivocal relationship between development in society and human health and well-being. 80% of our health depends on how we, as a society, attend to primary health care. Community-oriented primary care, COPC, is a proven approach to primary health. Through it, proactive healthcare teams bring public health and clinical care together to address the health needs of individuals and families in defined geographical areas. The Department of Health has begun a drive to re-engineer primary care. In response, the City of Tshwane, in collaboration with the Department of Family Medicine at the University of Pretoria, has initiated COPC through ward-based outreach teams as its model of primary care. South Africa is in the grip of 4 epidemics: HIV and TB, maternal and child death and diseases, chronic diseases like diabetes, hypertension and asthma, and violence and injury. Together, they take a terrible toll on people's health. These epidemics create a huge burden of disease that sees thousands of people searching for healthcare every day. The existing hospital and clinic system is swamped. At the same time, the huge amount of public and private money that is spent on health does not translate into better health for the majority. To deal with the epidemics and to improve people's health, we have to change the game. In healthcare, changing the game means changing where we play the game and how we play the game.
I like to think of healthcare like a game of soccer. The health system and the health workers on the one team, and the opponents are the epidemics. Although the health team has had some success, the epidemics are clearly winning. The problem is we have too much of a defensive game. We focus on the big hospitals where our specialists and nurses and doctors are struggling just to keep people from dying. What we need to do is we need to move the game to where the epidemics are active. That is in communities where people live, play and work.
In health, just as in soccer, the game changes when you move the game into the field. You start to play an attacking game. Healthcare workers become strikers, playing with the community, in the community. They start to prevent and pick diseases up very early. They stop disease before people get sick or infect others. This is the way you start to score against the epidemics and have a chance of winning the game. Like soccer, health is a team game. The role of all the players has to be clear and well understood. The nurses, doctors, specialists in secondary and in tertiary hospitals can only defend and limit the effect of the epidemics. But to score, we need the healthcare players in the community to become strikers. Our line of attack depends on the community health workers, the nurses, the general practitioners, the doctors, the ordinary men and women who live in the community. Together, they drive the attack against disease and ill health.
Bophelo bjalo ka papadi ge o nyaka go bona dipholo tse botse papading o a ikemišetša wa itukiša be wa tšhentšha le moralong go bjalo le mo maphelong a rena gore re kgone go phela gabotse re tshwanetse go fetola ka mokgwa re be re phela ka gona sa rena ke go tseba dinyakwa tša rena tša maphelo gore re kgone go di fihlela tšeo ka moka.
Technology is an enabler in these modern days. Through technology, we are able to provide health that is better, quicker, and of good quality. And it helps us to understand what is happening around us as in community. And for people that use technology, it shows that the data comes to them and they are able to provide a high-tech care to the community that they serve.
Our approach to primary care is oriented to the community. Community-oriented primary care comes from our own history. In South Africa, in the 1940s, Sydney and Emily Clark, together with Edward and Amelia Jali, pioneered a healthcare system for ordinary poor and disenfranchised people in Pholela. For 17 years, they used the best available knowledge and technology to innovate and create a holistic approach to health in the foothills of the Drakensberg.
What's truly innovative about their model is that in their practice they combined service and learning with information and research in a defined geographical area. They were responsible for the healthcare services, but what they did was make everybody responsible for their own healthcare. It was a collective activity.
There are 4 reasons why community-oriented primary care worked in Pholela in the 1940s and has worked in every place that it has been applied around the world since then. Firstly, it engages communities to address their own health needs. Secondly, it systematically attends to health and disease in a comprehensive and holistic way. Thirdly, it works from the best available information. Fourthly, it creates capability through continuous peer learning in the healthcare team and in the community. Doing COPC is a journey. You identify the place and space where you are going to work.
Selo sa ntlha se re se dirang ke go tlhotlhomisa gore mo lefelong le le rileng ke batho bafe le mekgatlho efeng e dirang ka tsa maphelo. Re be re kopanya batho ba gore mmogo re bona gore a re tlhaloganya WBOT ka go tshwana. Re be re itse gore mang ke mang yo dirang eng mo bathong le mekgatlhong e.
You recruit the local community health workers and assemble the WBOT. You start training for community-oriented primary care. You map.
We started by doing desk mapping using an urban planning map of Mamelodi. Working together with the team leaders, we divided wards into households, but we still needed to go out there and verify the number of households per ward by doing physical mapping.
Mamelodi, we have 16 team leaders, plus minus 300 community healthcare workers. From January, we started physical mapping. At the beginning of April, we had mapped 58,600 houses. And we still need to map 35,000 houses in the squatter camps, for which we still need team leaders and care workers.
You develop collections of questions and ask them to gather information. These questions become our tools because they give us information about the health needs that people have and where our services must go. We have developed the Household Registration Tool, or HHR. It gives us information about the characteristics and the social environment of households.
Information collected help us to identify those vulnerable community members that are vulnerable to health and social circumstances. And that will help us actually to enroll in other projects in the city, such as the indigent programs. It helps the city of Tshwane also to plan in terms of service delivery. That will help actually to uplift the life of the community that we serve.
We have also developed the Health Status Assessment, or HSA. It gives us information on each individual's profile as well as key indicators about their health. For example, if they are pregnant, and lifestyle like smoking. The HHR and the HSA are instruments to organize services and to monitor, evaluate and research community health and care. Up until recently, all information was collected using pen and paper. Now, with the help of information and communication technology, community health workers use their cell phones to guide them through the questions and to capture the answers. Technology is a great enabler. The process of delivering services is complex. We have to combine science with practice to get people to make decisions about what is the best thing to do. Applications loaded onto cell phones help people make decisions, but they don't make the decisions for them. People always have to make decisions. We say that ICT-enabled COPC is high-tech, high-touch healthcare. You learn and you make learning an integral part of service and care. High-tech and high science generates high-end healthcare practice only when you invest in learning. This is true for doctors and nurses. It is also true for community health workers, students, individuals and families in the community.
In community-oriented primary care, our place of learning is the community. We structure learning into service delivery. Our objective is to create capability.
Our method of learning is supported peer learning. Students and community health workers, nurses and doctors, professors and patients teach and learn from each other in a process of continuous education and training.
University of Pretoria has one of the largest community engagement programs in the country. Students from all our faculties are expected to contribute to community engagement and development. Currently, we've got 25,000 students. Through COPC, we are able to take community engagement to a new level through peer learning.
Capability happens when you know how to act using the best available knowledge and resources. Learning becomes authentic because you put what you know and what you do into practice. This is what we discovered and were able to do about TB in the community when we piloted COPC between 2011 and 2013. UP Family Medicine, together with the Foundation for Professional Development and Gauteng Department of Health, initiated COPC in 8 wards in Tshwane District. We followed the same processes that we have already described.
The most shocking thing what we found was that about half of the people with presumed TB and almost half of the people who had already been diagnosed with TB were not in contact with the health system for their condition. The existing health and information systems did not know about them. And even if that information had been known, the existing services would not have acted because they are not geared to act proactively.
Through COPC, we were able to change the situation. We used ICT to link the TB information back to the ward-based outreach teams. Team leaders sent community health workers out to locate and follow up on each of the people who had suspected TB. As a result, they got most people at risk of TB to go for testing. They also supported almost all of them to get onto and stay on treatment, and they screened most of their family members for TB.
This model of care changes the game against TB. It's because we have identified people in the community who are possibly infectious to others. They would have gone unnoticed if we just relied for them to come to clinics and hospitals. Now we go out to them, we get them tested, we get them on treatment. We also make sure that those who are most at risk, their friends and their families, also get tested and treated. By tackling TB in this way, we are able to improve the cure rates, and we are able to break the mechanism that drives the TB epidemic.